All right. So you have a lady with secondary hyperparathyroidism. What's the pathophysiology of hyperparathyroidism in CKD?
Okay, as a result of reduction in the alpha 1 hydroxylase enzyme, which helps in the activation of vitamin D. And when there is deficiency of vitamin D, there's reduced calcium absorption leading to hypocalcemia, and this sends a negative feedback to the parathyroid gland, causing secondary hyperparathyroidism.
Yeah, right. It's not the 1 alpha hydroxylase. Yeah, actually the 1 alpha hydroxylase, but you have deficiency in the 125 dihydroxy vitamin D, and this leading to hypocalcemia with the positive feedback, etc., and overproduction of the parathyroid hormone. Well done. In parathyroidectomy, what test to do to identify the parathyroid tissue intraoperatively?
Do the frozen section via the Mohs microsurgery.
Yeah, you would be asked here, what is frozen section?
Um, Section, it's a method of collecting sample. So what happens is there is a metal slide where the tissue is collected or transported, and then this is put in a medium called the OTC medium, and then a cotton, yeah, in the OTC medium, and then stored in a low temperature, and then it is cut and stained with immunohistochemistry and viewed under the microscope.
Yeah, I made a good answer, but I think it can be better. All right. So try to divide this into steps. Try to think how it's actually done in real life. All right. So, first of all, you take a surgical specimen. Second of all, you put it in a metal tissue disc, and then you drop the temperature to -20 to -30. And then you put it in a gel like medium that's called OCT, which is basically like formalin, for example. So it's polyvinyl alcohol or polyethylene glycerol to preserve the tissue. And then you get a microtome, you cut it into small pieces, you look into the microscope, and you put hematocrit and AUC. Right? Some steps.
Okay.
Right? Take samples, put on a glass rod, get temperature down, put it on something to preserve it, which is polyethylene glycerol, cut it by the microtome into small pieces, look on the microscope, and also put some hematocrit and AUC. Right?
Right.
The genitourinary complications of renal stones.
Okay. Of the stones, which could lead to hematuria as the stones go down the ureteric phase. Then there could be obstruction leading to hydronephrosis. Obstruction. This hydronephrosis could then cause like pressure to the kidneys, leading to acute kidney injury. Also, there could be infection and then metaplasia from chronic irritation.
Yeah. I mean, you can classify it. You can classify it into obstructive, infective, and also malignancy as well, if you want to add this. Neuropathy that can lead to hydronephrosis and anuria and kidney failure or acute kidney injury. An infection, you can get pyelonephrosis and pyelonephritis. And then you can also add malignancy for very chronic renal stones, can lead to squamous cell carcinoma. How stones can
Cause cancer, chronic irritation of the epithelium of the epithelium, leading to damage of the DNA, which would then cause proliferation of these cells, leading to the development of the cancer.
it's mainly chronic irritation, but you still need to add a few words here. All right.
Okay.
Chronic irritation, what will it lead to? It will lead to DNA damage in the proliferating cells. And that's the key point, all right? DNA damage. So this will lead to production of oxygen and nitrogen species that are produced normally by the cells to fight infection. Okay? Substance is called peroxynitrite, which is a mutagenic agent. So it will lead to some mutation. Okay? It would interact with the DNA in proliferating epithelium and will lead to permanent genomic alteration, such as point mutation or deletion or rearrangement. And this is basically what leads to cancer. So chronic irritation is not an enough answer to get the full mark. So chronic
Oh,
inflammation, DNA damage to produce substance called peroxynitrite, which is formed of mainly oxide and nitrogen, right? Peroxynitrite. This substance is mutagenic and can lead to permanent genomic alteration, such as mutation, point mutation, and deletion and rearrangement as well.
right.
Okay. This is the most common type of cancer in renal pelvis cells.
Transitional cell cancer,
What is the most type of cancer in kidney?
renal cell carcinoma,
what to look for in histopathology report from a removed kidney was renal cell carcinoma.
Okay, looking out for gross and then microscopic features. So in the gross features, are looking out for the size of the tumor, the margins. We're looking out for type of the tumor. In microscopic, we're looking out for the immunohistochemistry code.
That's Althea, question, it can't go wrong in the exam because it's a generic question that you will find it's being asked in pretty much every tumor. All right? You have to
Yeah.
work out to remember what you're saying. So, like we said, if you get a histopathology report, you have gross picture, microscopic picture, special tests, and conclusion. So, in gross picture, you're looking at the tumor size, shape, margins, ulceration, necrosis, the state of the blood vessels, whether there is invasion to the blood vessels or not. Microscopic picture, you're looking into the type and the shape of cells, all right? Presence of anaplasia, the degree or the differentiation of the tumor, okay? You can also look at the margins again, and you can look at presence of lymph node and also the lymphovascular invasion, the differentiation and the grade, etc. Okay? And
Okay.
gross picture size, describe the appearance and the location, necrosis, ulceration, invasion of vascular structures, and microscopic, many other things as well. The tumor type, there is a WHO classification. It could be many things. You don't have to mention all of them. Clear cell, papillary carcinoma, chromophore cell carcinoma, etc. You don't have to mention all of them. We talked about margin resection, and the renal cell carcinoma could be R0, you've cured the tumor. R1, it's microscopic residual, and R2 is macroscopic residuals. You can actually see lymph nodes, number of lymph nodic size, and number of positive lymph nodes. All right. Cool. Overall, your performance is good. You just need to detailed answer, all right, rather than giving a fairly short answer in some questions. I mean, like I said, you need to be short in the exam on succinct, but that doesn't mean that you ignore the key part of the answer. For example, this question, you should have been a little bit more specific on what do you mean by chronic inflammation. Yeah, we understand chronic inflammation can lead to cancer, but how? How did this happen? Classification in this question could have been a little bit better. Obstructive and infection. Um, for frozen section, you could divide into tips so you wouldn't miss any. You've answered this question very well. I mean, this question was fairly straightforward, and this question, it can't go wrong in the exam. All of you need to remember it very well because it's pretty much asked in every tumor question.